Diagnosis of pulmonary embolism. The visualization of an intraluminal filling defect is the definitive diagnosis. Sometimes the cutoff of pulmonary arteries are an indirect way of establishing the diagnosis of an obstructing intraluminal process. Pulmonary angiography is being replaced by CT angiography as the gold standard for the diagnosis of pulmonary. CT angiography for pulmonary embolism. It is generally available, relatively inexpensive, and minimally invasive. It visualizes directly the thrombi, assessing the location and degree of clot burden. It provides an alternative diagnosis in 75% of patients who do not have pulmonary thromboembolism. For example, they may have a pneumonia, atelectasis, a pericarditis, dissecting hematoma of the aorta, or even a myocardial infarction. A negative predictive value is a 99 to 100% if technically adequate. CT venography can be performed at the same setting without administration of additional contrast material. Therefore, we will be able to make the diagnosis, but also to establish the site of origin of the emboli. CTA for pulmonary embolism. A negative CTA provides a sufficient reliable criteria to exclude the pulmonary embolism. It reliably depicts emboli in 2 to 3 millimeter vessels in segmental and most subsegmental arteries. Subsegmental emboli are not of clinical significance according to the PIOPED study. The negative predictive value is 99 to 100% if technically adequate. The technique for CT angiography when studying pulmonary emboli consists of a 2 to 3 millimeter collimation, 1.5 millimeter reconstruction, and 1.7 to 2 pitch. Acquisition is obtained in a corocranial direction. The technical factors are 140 kVp, 220 MA, and 100 to 100 milliliters of a non-ionic contrast material is injected into a peripheral vein at a rate of 3 to 5 milliliters per second. There is a delay when we note a rise to 50 Hounsfield units in the main pulmonary artery at 7 seconds. The test bolus peak plus 5 seconds. The acquisition time is 20 to 30 seconds. The multi-slice CT is faster because of a shorter breathing holding, a thinner collimation of 1 millimeter, and the acquisition time is 8 seconds with 2.5. CT angiography for pulmonary embolism. The diagnostic criteria are as follows, and one must distinguish between an acute and chronic pulmonary embolic phenomena. Intraluminal filling defect, like with pulmonary angiography, occupying the lumen or part of the vessel is the most reliable sign, and it must be seen in more than one consecutive axial image. A tubular shape thrombus may be seen. In chronic pulmonary embolism, we should look for calcification in the wall of the pulmonary artery. Also, filling defects attached to the intima that often are long filling defects. Enlargement of the pulmonary artery proximal to the thrombus is another sign. And finally, tortuosity of pulmonary arteries, which often is related to the chronicity of the pulmonary hypertension. These are examples of filling defects. On the right side, note that the right pulmonary artery has an intraluminal filling defect, and on the left side, a larger intraluminal filling. These are examples of long tubular filling defects due to thrombi at the bifurcation of the main pulmonary artery. Notice the one on the left side, and also the similar findings on the picture to your right. These are more examples of tubular filling defects. Note to your left that tubular filling defects are noted in right lower segmental branches of the pulmonary artery, as indicated by the red lines. There is a meniscus of contrast material surrounding the thrombus, as seen also in the picture to your left. On the right side, note the visualization of a tubular-shaped filling defect in a left pulmonary artery. In this scene mode, note the filling defects proceeding craniocaudally and caudocranially. Note that they are present by. Note the effects of thin collimation. Filling defects are seen in transaxial vessels by using thin collimation. Note the calcification observed in chronic pulmonary thromboembolism. On the left side, without injecting contrast material, note the rim of calcification in the proximal left pulmonary artery. On the right side, following the administration of contrast material, a typical filling defect with a cup-shaped termination of the left pulmonary artery, beyond which we see a large filling defect is indicative of the presence of a large thrombus. Technical limitations of CT angiography for pulmonary embolism include the poor vascular opacification seen in patients with congestive heart failure, the noise that results from obesity, motion artifacts, atelectasis with crowded pulmonary arteries, and the presence of pleural effusion. False positive studies may result from pulmonary veins, breathing artifacts, and the presence of hilar lymph nodes. False negative studies may be the result of very small peripheral subsegmental vessels, which generally are clinically insignificant, according to the PIOPED study. And finally, suboptimal opacification of the pulmonary artery. Elegant multiplanar reconstruction of the pulmonary vasculature permits simultaneous visualization in the sagittal, coronal, and axial planes. The 3D reconstruction may look like an. Note thrombus in the right pulmonary artery in a patient who had a left pneumonectomy. Observe the filling defect in the axial, coronal, and sagittal